thyroid. Okay. Again, remember that the anterior pituitary put out thyroid stimulating hormone, and it typically is the hypothalamus that put out first thyrotropic releasing hormone. Then the anterior pituitary put out thyroid stimulating hormone, which then put out T3 or T4, and T3 or T4 negative feedback so that the thyroid stimulating hormone decrease or thyrotropic releasing hormone is decreased. If you have tumors here, right, this could lead to increases T3 or T4. We know that, all right? So it will be hyperthyroidism. But in this case, if there's a tumor here, then TSH is high, right? Now, on the other hand, if it's a tumor here, you might see the same thing, increases T3 or T4, right? But because there's negative feedback, in this case, TSH is decreased. So by looking at hyperthyroidism is the end result, right? T3, T4 is high. Let's look at what happened to the thyroid stimulating hormone. Is it high or low? If it's high, most likely tumors in the brain, in the anterior pituitary. Is low, it's in the tumor here, right? Or, in fact, what happened is that Graves' disease is an autoimmune disease in which the antibody here looks exactly the same. Here's my sign for the same as thyroid stimulating hormone. And so instead of having thyroid stimulating hormone stimulate the thyroid gland, the antibody is doing that. The antibody is stimulating this. Okay, so how can you distinguish between a tumor in the thyroid, like toxicology, Plummer's disease, or Graves' disease? How can you distinguish those two? Well, in this case, the antibody is present. In this case, the antibody is not present. How can you distinguish this from a tumor in the anterior pituitary? Well, in the anterior pituitary, thyroid stimulating hormone were high. But in both of these cases, thyroid stimulating hormone would be low. That takes a little bit of thinking. So take a couple minutes to think about that. Okay, so thyroid gland. There are some development problems with thyroid gland, hyperfunction, so we can call that as hyperthyroidism, or less secretion, hypothyroidism. Hypothyroidism common is Hashimoto disease. Again, it's an autoimmune disease that pretty much destroy the follicular cells. Might be T cell mediated and so forth. Thyroiditis, very similar inflammations in the thyroid can lead to hyposecretion. And then, of course, there's thyroid tumor. Okay, and I'll tell you the different types of different types of thyroid tumor, and how you can remember them as which one is more frequent relative to the other one. Okay, papilloma, follicular, and so forth. Okay, so thyroid angiogenesis leads to hypothyroidism. Okay, so there's certainly there, just like a person who's born without thymus, there are people born without the thyroid gland. They usually don't do very well if they don't have it, because in fact, we'll find out that in hypothyroidism, particularly in children, can lead to cretinism, which is like a form of mental retardation. And that's because there's a lack of T3 and T4, whose is important for metabolism, and low T3 or T4 could lead to essentially is cretinism. In fact, T3, T4 stand for triiodothyronine or tetraiodothyronine or thyroxine, which means that you require iodine to make functional T3 or T4. If you don't have any iodine, then you can't make functional T3 or T4. And in the U.S., we will see that the common cause of cretinism is due to pregnant mother does not have any prenatal care, particularly lack of iodine in her diet during pregnancy. Okay. Thyroglossal duct, and this could basically just typically is a duct, like we say here, that is flowing from the tongues to the isthmus. Sometimes there's fluids filled against the cyst, just in this case, basically the cyst could lead to some pain. That's it, and it could lead to an infection. So that's just your thyroglossal duct cyst. All right. Okay, so as you can see here is that this is thyroid overactivity. So in other words, you're going to say that this is hyperthyroidism. Hyperthyroidism, and this one is your hypothyroidism. Okay, and to make our life easy, since hyperthyroidism tends to be increased metabolism, and the person is burning up, right? You can see all these signs and symptoms, but whenever you come across my description of being heat sensitivity, right, then boom, you think of as hyperthyroidism. This person is burning up, so they're very sensitive to heat. In this room, it's oh, it's too hot, for example. Whereas hypothyroidism, it'll be cold sensitivity, right? And someone's cold sensitivity, the metabolism is low, and so they do not have enough heat. And then you say, oh, it's too cold in here. When most of people think it's just your average 76 degree or 72 degrees Celsius, 72 degree Fahrenheit room temperature. In Celsius, probably like around 25 degrees, 26, 27 degrees Celsius. So cold sensitivity is hypothyroidism. Hyperthyroidism is heat sensitivity. Right? But certainly someone would have, say, if you just go down the list, you can see here exophthalmic, which is actually very common with person with Graves' disease. And that's another way to distinguish between Plummer and Graves' disease, is that the antibody that mimic the thyroid stimulating hormone also reacting to the recti muscles in the eye, so you can get exophthalmic. But in the case of if you have a tumor in the thyroid, then they don't have that antibody, and that they don't have exophthalmic, for example. Okay. Thyroid gland tendency to be bigger. Weight loss is important. That's key. Extra heartbeat is harder to see. Warm, velvety skin, typically that. Okay. Now, on the other hand, hypothyroidism, what you will see is that they're slow metabolism, so they tend to be on the heavy side. Weight gain, okay. Doty, sort of like dry skin. Okay, maybe I have hypothyroidism. And some edema into the lower extremity, but very important, that will be cold sensitivity. Okay. Hypofunctions of thyroid gland, hyperthyroidism. Okay, in the case of uh, Graves' disease, okay, so this would be Graves' disease, exophthalmic, that's protruding eye, enlarged thyroid gland, tachycardia would say that increased heart rate, weight loss, tremor, sweating, that's also very important because they're hot. They're trying to keep their cool by sweating. Anxiety, restlessness, uh, basically fewer for female menstrual period or none at all, oligomenorrhea or amenorrhea. TSH uh, in this case is low. Why? Right. Typically, this will be negative feedback. Remember, we talked about negative feedback. TSH will be low. If TSH is high, that leads to a hypothyroidism, then there's a tumor, right, in the anterior pituitary, right, of that basophilic cell. So this basically, so essentially the thyroid gland have follicular cells who make these thyroglobulin. Thyroglobulin is just a link of precursor form of tyrosine links together a whole bunch of tyrosine and removes of that tyrosine will then becomes your thyroxine. Okay. And remember, I don't know if you guys took 301 here, but these we'll consider as a single layer of cuboidal. Okay, simple cuboidal is the thyroid gland. You see there, and thyroglobulin is finding here. It's just basically a whole bunch of carbon like that structure. And here's important, if it has iodine here and here, that's tetraiodothyronine. If it's loose one, is triiodothyronine. But iodine is important, right? Iodine is important. So in this case, what you see is hyperplasia of the thyroid gland that you see here. Notice it's actually, I would say that the magnification here is a little bit higher magnification than this. Okay. So this is to show you that the follicular cells here have much darker staining. Okay. And some of them, they lose out. See how each of the follicle has thyroglobulin? Here's only a few of them have it. But look at over here. Yeah, this looks like it's pretty dysmorphic cells and stuff. Hyperchromatic staining. That's your kind of considers precondition, pre-cancer, for example. Okay, so Graves' disease, we're talking about it. In fact, there are 3 causes or potential causes of hyperthyroidism. Graves' disease, toxic goiter, also known as plumber's disease, and the uses of amiodarone, which is basically an antiarrhythmic medication, like your heart disorder, that because this amiodarone looked like T4, that's why it stimulates the thyroid gland to put out T3 or T4. So basically, essentially, when you have hyperthyroidism, think of this as well as the tumors in the anterior pituitary. Okay. And then you have to rule this out. In Graves' disease, autoantibody is present. This one is not. In amiodarone, of course, someone is taking the drugs. But usually it's hypothyroidism are these three conditions. So in other words, I might write a question and say, okay, which one of the is not contributing to hypothyroidism? Greater Z, yes. Toxic goiter, yes. Uh, use of amiodarone, yes. Tumors in the anterior pituitary, yes. Right. Damage of the um, damage of the hypothalamus. In fact, you would think so, but no. The correct answer is damage at the hypothalamus, um, which most likely will lead to diabetes insipidus. Okay. Gray disease, we already talked about this already. Most common cause of hypothyroidism. It's an autoimmune disease. IgG antibody resemble, actually binds to the thyroid stimulating hormone receptors of follicular cell, therefore stimulate T2, T4. Again, as an autoimmune disease, it's very common in females, usually in 40 to 30. Very indicative is that protruding eye, exophthalmic. Okay. And histologically, you can say, oh, the the colloid or thyroid globulin within the follicular is decreased. Okay. Grave disease. Now, this compared to toxic goiter, multinodular goiters, or plumber's disease. When we talk about goiter, we just basically is enlarged thyroid gland, and most of that due to iodine deficiency, if you will. Certainly goiter, because essentially is that the thyroid, if you don't have any iodine, the thyroid gland trying to make T3 and T4, but they can't, right? Not functionally, and then T3, T4 low, negative feedback, thyroid stimulating hormone is high, it's just continuous stimulating it, and it go bigger and bigger, and that's why you get goiter. But over time, that that there's no longer response to that, so to the thyroid stimulating hormone, but you still have goiter. Okay. So in the case of toxic nodule goiter, just basically enlarged thyroid gland. In the plumber's disease, is that they also put out a lot of T3 or T4, right? And plumber's disease is a second cause of hypothyroidism. What is number one? Grave disease. Okay. So in this case, with plumber's disease symptom, overact the thyroid gland, but however, you do not have any exophthalmic. So that's how you can distinguish between plumber versus grave disease. Okay. All right, so hypothyroidism mean the opposite of that. Not a lot of T3 or T4 is produced. The most important is idiopathic, I guess you can say this, autoimmune disease or Hashimoto disease. Okay. Hashimoto disease. What is causes of hypothyroidism? Inadequate secretions of thyroid stimulating hormone, reduced secretions of either thyroid stimulating hormone or thyrotropic hormone, and this basically reduced secretions of this could be due to the mass effect of nearby tumor, if you will. Okay. Other causes is just basically lack of iodine or even mutations in the thyroid hormone themselves. And then, of course, surgery or radiation can also lead to hypothyroidism. Okay. Congenital, idiopathic, and goitrous hypothyroidism hypothyroidism. Hypofunction, you can see that T3 or T4. So in the case of hyposecretion, because there is low T3 or T4 negative feedback, you see that high levels of thyroid stimulating hormone. Okay. In the case of maybe it may not be related to Hashimoto disease, which is also an autoimmune disease in which there might be antibody that is affecting the thyroglobulin, okay, or the thyroid peroxidase. All right, so we're going to see that congenital hypothyroidism is cretinism, okay, and in the U.S., what causes cretinism is usually due to iodine deficiency in the mother, if you will. So you don't have any iodine, you cannot make functional T2 or T4. And we saw already in cretinism, at least it's a form of mental retardation or congenital hypothyroidism. Typical signs you can see paraorbital edema, large tongue. It's it's like, I don't know. Sometimes you look at the kids, you would know something is not normal. Wide sets of eye. I used to have a figures here, but I don't know where to go. Okay, so in adult, it's known as mixed edema, is adult hypothyroidism, and in mixed edema, typically someone might exhibit what's called mixed edema madness, which exhibit hallucination, psychosis, if you will. All right, so in congenital, you can either have cretinism or mixed edema. Okay. In goiter and toxic goiter versus non-toxic goiter, it's just a general term. Non-toxic goiter mean that there's no secretion, but toxic goiter is secretion. Okay. Well, the only way to distinguish those two is just to gross anatomy, looking for the thyroglobulin, if you will. Okay. If it's hyperthyroidism, high T3 or T4, how can you distinguish between toxic goiter, also known as Palmer's disease, or Graves' disease? Let's look at this guy right here. Does anybody want to know why, again, why is he not? He has hyperthyroidism, yeah, in this case. And T3 or T4 is very high. Look, he's very skinny, very skinny on one side. How can you rule out that it's not Graves' disease? This is not Graves' disease, but might have hyperthyroidism. How can you rule it out? Look at his eye. Okay, it's not protruding. That's how you can. All right, so toxic multinodular goiter, Palmer's disease. Typically, look at that guy as an example. Well, I should have a female. They typically are older, not typically seen in children. Symptom, of course, hyperthyroidism. The bulging eyes, again, in Graves' disease not occur. And again, it's the second most common cause of hypothyroidism after Graves' disease. All right, there are different causes of thyroiditis or inflammations of the thyroid that could result in hypothyroidism. infectious thyroiditis caused by either bacterial, viral, and so forth. But if autoimmune disease, we consider this Hashimoto. Okay, Hashimoto is the most common one I would probably use in terms of hypothyroidism. It's the destruction of thyroid glands by autoantibodies. You see that the most common cause of hypothyroidism in the United States, Hashimoto disease. Again, it's very common in women. There is the Quervain thyroiditis. I'm not going to talk about this, but that's just basically granulomatous inflammation. DeQuan's thyroiditis. This guy described many different kinds of conditions in the body, like contribute to carpal syndrome and so forth. But Hashimoto is the one that you should be really focused on regarding hypothyroid. Hashimoto, see, you can see that in this case, this might look like a normal thyroid, okay? Although it might be in the same lesion, but the nearby lesion, you can see here how you get a lot of immune cells recruited into this area. Again, pretty much similar accumulations of these cells. They're not only just plasma cell, there's some T cell, so I think that's why it might be T cell mediated. Plasma cell, of course, will produce the antibody, and those antibodies most likely is reacting to the thyroglobulin. All right, so before we take on a 5-minute break, there are 4 different types of cancers in the thyroid gland. If it's malignant, of course, it's benign, they're adenoid. The most common one is called papillary carcinoma. The second one is follicular carcinoma, medullary, and anaplastic carcinoma. This one is rare, but that one has the worst prognosis, if you will. The papillaries has pretty good prognosis, and medullary has also pretty good, not the follicular. But you want to know, for example, the order of most common versus less: papillary, follicular, medullary, and anaplastic. You just think of this. Please fill my ass. Right? All right, so that's how you remember it. The 4 different types of malignant thyroid tumor. Okay. So the malignant one of the papillary is the most common, as you can say. It has very good prognosis. Tend to be seen in women, and particularly women who has frequent radiation. Okay. Histologically, the cells will look like what we consider aneorphic nucleus, if you will. Okay, so this is what aneorphin look like. And see how the eyes here is kind of like very round. And this is the medullary. This is the papillary carcinoma of thyroid, and you can see how papillary. Okay, and these cells are very round. So in other words, in the future, when say histologically look like aneorphin nucleus, right? You should think of papillary carcinoma of the thyroid gland. Okay. Pretty good prognosis in the woman's in the 50. That's please. Okay. The second most common is follicular carcinoma. Very much the same populations of group, but it's this is actually the tumors of in the follicle. It's not unique anything to describe you, other than that it's slow growing, it's not very good prognosis. Medullary carcinoma, the medullaries come from the outside, which is more like the C cell, right? So the C cells are the cells that sit on the outside that secrete calcitonin. And calcitonin function is to decrease your blood calcium level. And medullary carcinoma, we're going to see, is that is associated with MEN3. Okay, what is MEN? MEN stands for multiple endocrine neoplasia. There is there's 3 types. There's type 1, type 2, type 3, and I will tell you them how to distinguish between them, because there's usually a group of tumor that finds in 3 organs that related with the 3 Ps. The pituitary, for example, pancreas, or the thyroid gland, for example, or 2M and a P, medullary carcinoma, like you see here, or the pheochromocytoma. What is pheochromocytoma? I'm going to talk to you a little bit, but suffices to say, for you need to know by now, is that the 4 malignant types of cancers in the thyroid glands are the papillary, the follicular, the medullary, and the anaplastic. And the papillary is the most common, have good prognosis. The follicular, slow growing, not very good prognosis, but the medullary is, and medullary is part of the MEN syndrome, or type 3. Okay, it has pretty good prognosis. And the medullary carcinoma are tumors, cancers of the C cells. Okay, and the C cells will produce a lot of calcitonin. And the anaplastic carcinoma, which has the worst prognosis, that is, you have chronic people who have a loss of iodine deficiency, or goiter, that can lead to cancer. MEN3B, the MEN3B, MEN3 or type 2B. Type 2 is considered as 2. So the old abbreviation is either MEN1 or MEN2, and MEN2 is divided into MEN2A and MEN2B. So MEN3 here is really type MEN2B. So think of this as the multiple endocrine neoplasia, type 3, and think of this as associated with the 3 M's, right? What are 3 M? The medullary thyroid carcinoma, the medullary, the medulla of the adrenal gland, known as pheochromocytoma, and then mucosal neuroma, which is basically a benign tumors of the nerve cells. All right, so MEN3, 3 M's, easy to remember. Let's take a 5-minute break here. Are there any questions? Any question? We can come back and talk about MEN1 and MEN2 later on. Okay. Any question? Okay, so no question. Let's stop here.